All right. Hello, everyone, and welcome. Thanks so much for being here today. My name is Fifi Nuguse, and this is the Data to Action Supporting California's Small Independent Practices webinar, and it's hosted by the California Improvement Network. This session is about turning evidence into practical strategies that can actually support the small independent practices. And as you all know, these practices play a significant role in delivering equity-centered care. So today you'll hear recent data and real-world lessons and concrete strategies for how payers, purchasers, and policymakers can better support these practices to thrive. Next slide, please. So before we dive in, I just want to do a quick background on who we are. So CIN, or the California Improvement Network, is a learning and action community focused on advancing equitable healthcare experiences and outcomes across California. So we do this by creating connections across sectors, spreading good ideas, and supporting action through webinars like this one. We also do affinity groups, we host workshops, share resources, and then we also have grant-funded action projects. Next slide. So CIN is a program of the California Healthcare Foundation, and it's managed by Health Force Center here at UCSF. Next slide. So during the hour today, we'll hear from three speakers, and then we'll also have a breakout group discussion. So as you're listening, if the reflections or questions come up for you, please just put them in the chat, and then our speakers will be responding in real time. And then towards the end of the session, we'll ask for some brief feedback. I think it's three questions on the poll, so that we can continue to offer content that is both relevant and responsive to the work that you're doing. So we hope that you'll stay with us through the end, and then share your thoughts and experiences. Next slide. All right. So now I'm excited to introduce our three speakers for the day. We have Diana Camacho, Senior Program Officer at the California Healthcare Foundation. We have Jill Yagian, who is a healthcare market and policy consultant. And we also have Peter Robertson, Senior Director of Practice Transformation at the California Quality Collaborative. So welcome to our speakers. Thank you so much for being with us here today. And with that, I'll invite Diana to kick us off.
That shows that in 2022 alone, Medi-Cal enrollees had about 20.4 million primary care visits. 2.1 million of those visits occurred in solo and small non-FQHC practices. That's about 10% of all Medi-Cal primary care visits and 15% of visits to non-FQHC providers. That's a meaningful share of visits across the state. And these are for practices that are often invisible to our policy and investment conversations. I'll also note that the importance of small practices is even clearer at the local level. In several large, high population counties, including San Bernardino, Riverside, Orange, and Los Angeles counties, small practices account for 15 to more than 20% of all primary care visits within the Medi-Cal delivery system, well above statewide average. In these communities, small practices are not on the periphery, they are central to access. Yeah, as I mentioned, historically, small practices have been overlooked, often assumed to be too small to change or too fragmented to invest in. And that assumption has had real consequences. Many of these practices struggle to meet quality benchmarks, not because of lack of commitment to patients, but because they often operate with limited infrastructure, capital, and administrative support. At the same time, we know that small practices bring strengths that the system cannot afford to lose. They are deeply community-based. They often provide culturally and linguistically provided care in their communities. Evidence has shown that they are associated with lower rates of preventable hospital admissions and lower clinician burnout, pointing to more sustainable relationship models of care. This is why CHCF chose to invest in small practices years ago through the Equip LA initiative and the work that Jill did, which you'll hear more about. And because we really truly believe that if Medi-Cal is serious about equity, access, and delivery system transformation, we could not just focus on large institutions. We had to focus on the small practices that were providing critical care to our communities. So, to understand what these realities look like on the ground, Jill will talk a little bit to what she heard in some interviews, and then Peter will talk about the practice transformation work that happened in Los Angeles County. With that, I'm going to drop in the chat a resource if you're interested in learning more about small independent practices and who they are on our website. But with that, I will hand it over to Jill, I believe.
Great. Thank you, Diana. It's great to have an opportunity to participate in this dialogue. I'm Jill Yegian. I'm an independent consultant, and this work was conducted with support from the California Healthcare Foundation and partnership from the Primary Care Investment Coordinating Group of California, or PICG. Next. For this project, I conducted interviews in the spring of 2024 with 15 independent primary care practices in Humboldt County in rural Northern California and in the Inland Empire, Riverside and San Bernardino counties. I also interviewed 7 leaders and subject matter experts on the topic. There was a range of sizes of the independent practices, from 1 solo physician to 7 physicians and multiple nurse practitioners or physician assistants. Most of the practices were quite small, and there is a table in the brief that provides details. Next. The interview surfaced 8 themes across the 2 regions, and the brief outlined some additional region-specific findings that I won't cover today. First, those running independent practices felt strongly about autonomy, flexibility, and the ability to practice medicine in line with their values. Many had worked in corporate practice settings previously, so they understood the alternatives. It is hard to run an independent practice, and so each one was making a conscious choice because it was worth it for them. Second, practices are experiencing increasing costs and flat revenue and have little control over either, so they feel squeezed. One of them said, "Our costs for things keep increasing, but we don't really have a way to change what we charge people. We just get what they give us." Third, changing government policies and funding streams make it challenging to plan and invest for the long term. Interviewees reported experiencing that the state will make a commitment, such as a target rate increase for primary care providers, and then delay implementation when there's a budget short. For practices making plans to expand to a new site or hire new staff, this feels like the ground underneath them is constantly shifting. Fourth, practices have many ways, often creative, to make financial ends meet. For example, some have a side gig doing procedures to increase revenue. Others have created efficiencies with offshore staffing or created a distinctive brand that differentiates them in the market to attract and retain patients. Fifth, many practices have specialized in specific payer types like Medicare or Medi-Cal to more effectively manage the complexity of payment arrangements, coding, billing, and reporting requirements. Practices must invest in learning the rules for each payer type and to staff appropriately to meet requirements. Almost half of the practices did not accept Medi-Cal, and those that did tended to have a large share of Medi-Cal patients. Sixth, from the perspective of the practices, there is no perfect form of payment. Capitation tends to be more aligned with the primary care perspective on managing a population than is fee-for-service payment, but it's sometimes inadequate to meet patient needs. Seventh, in the Medi-Cal market, providers rely heavily on incentive programs offered by the health plans, but they have a mixed experience with those programs. And last, when asked about the outlook for the next 5 to 10 years, the physicians generally planned to maintain or grow their practice or were looking toward retirement. There was not much interest in selling to a health system or other corporate buyer. Next. From the interviews, I surfaced 5 opportunities to help sustain independent practice. First, reduce administrative burden by aligning processes and requirements across the payers. Variation and complexity are very hard on small independent practices. Sometimes it's necessary, but often it's not. Second, support business operations of independent practices. I asked each physician what would help their practice thrive. And the box on the left features several of those ideas, ranging from a playbook for independent practices to help with recruitment or a shared pool of temporary staff. Third, actively encourage physicians to start or join independent practices. Make it financially feasible and more appealing to revitalize this sector. Fourth, commit to long-term investment in primary care, including increasing primary care reimbursement and center independent practices in that effort. And last, consider independent primary care practices, including rural practices, in policy and purchasing decisions. Some of the legislation and policy decisions that come out of Sacramento have created unintended consequences for small practices and hit rural practices especially hard. Next. There are some great efforts underway across the state already to support independent practices, and I wanted to highlight just a couple of them. There is more information in the brief. The California Medical Association and county medical associations across the state offer programs tailored to independent practice. One to highlight, the Population Health Fellowship in Inland Empire offers residents who have completed their third year a combination of financial support, sign-on bonus, salary contribution, and contribution toward loan forgiveness, with a one-year training curriculum in population health management that provides them with practical skills. Another, the state has made a $140 million investment in the Equity and Practice Transformation Initiative, which includes many small practices in the cohort of participants receiving support with building capabilities and infrastructure for population health management. Next. So what can we do to strengthen independent practices? Purchasers can align their contracts with health plans to reduce variation and administrative burden. They can contribute to pooled resources that could be made available to independent practices for the types of supports mentioned earlier, such as shared staffing. And DHCS could simplify and support the ability of independent practices in rural areas to become a rural health clinic, a specific designation for practices seeing a large share of Medi-Cal that can increase revenue and financial sustainability. Payers, which includes IPAs, can work with purchasers and each other to align. Again, reduce variation and administrative burden for practices. They can offer tailored payment models, such as shared savings with technical assistance in adoption. They can develop regional resources to support independent practices in a geographic area. And they can intentionally include independent practices in efforts to support provider adoption of innovation, such as AI scribes, to help make sure they don't get left behind. Policymakers can create a loan program or a tax credit for independent practices. They can invest in practice transformation for independent practices, much as DHCS is doing now with the Equity and Practice Transformation Program. They can consider unanticipated consequences of new policies. How will this affect not just large health systems, but small practices? And how will the policy affect small practices in rural areas as well as big cities? And with that, I will turn it over to Peter and look forward to the discussion.
Thank you, Jill. And good afternoon, everybody. I'm going to share my slides. I'm hopefully going to play a video in a moment, and it's a pleasure to be here this afternoon and to talk a little bit more about the Equip LA program that the California Quality Collaborative ran in partnership with CHCF and a number of other partners over the last few years, and to share some lessons about how we can actually go about supporting small practices here in California. And I think to start the conversation, I actually wanted to share a few words from one of the participants in Equip LA. So in a moment, you're going to hear from Dr. Azorin and his staff and care team at Tweedy Medical Group. They were one of 31 practices that engaged in the Equip LA program. And his staff's reflections on what this program meant to them, their patients, and the community that they're involved with. So I will get this video going.
We all need help. There's only so far that as a small clinic that you can take it, But then when Equip came around, it was just reaffirming everything that we were doing, but it was also our way of being able to connect now with the larger healthcare system.
They've really been able to provide a model and creative ways to think about how to open up conversations amongst different clinics, amongst different organizations to get feedback, and then to be able to take that and of course translate into how do we make that work best for our clinic here and our subset of patients.
For the longest time, we just felt like no one cared about us as a clinic. But now we have someone to support us and challenged us to, even do more.
Okay, I hope you could hear that. That came across okay. But that was a little snippet from Dr. Zorin and his practice, Tweedy
We
Medical,
all need help.
about their experience in Equip. And so, as I've already mentioned, Equip was a 2-year improvement collaborative engaging 31 practices across Los Angeles County. And you can see each of those practice locations reflected on this slide here. They were engaged and brought into the program through one of 4 provider organizations. We worked and partnered with 3 independent practice associations, Allied Pacific IPA, Angeles IPA, and Omnicare Medical Group, as well as LA Care, one of the medical health plans down in LA County, their direct network of primary care practices. Our overarching goals when we embarked upon this work back in 2023 were to really build the capacity of each of these practice participants to focus on equity-centered quality improvement, to drive meaningful advances and address disparities for Medi-Cal members in 3 clinical areas related to diabetes, hypertension, and colorectal cancer screening. And in doing so, not only building their capacity within the program for quality improvement, but their longer-term capabilities to deliver on advanced primary care. And this is a definitional piece of work that the California Quality Collaborative has led for several years. So Equip-LA, as Dr. Zorin mentioned, was all about relationships and building trust and partnerships as a result of this program. And Equip itself wouldn't have happened without an amazing group of partners who helped operate and run this program over a 2-year period. You can see many of them reflected on the slide here. So alongside ourselves, we worked with Health Begins as our health equity advisor, PFCC partners who are our patient and family engagement advisor, community partners who've served as the program administrator, and CCHE who served as our evaluator, alongside 2 of our managed care plans in Los Angeles, both LA Care and HealthNet. So what did we do over the 2 years? Well, through our provider organizations, we actually supported the development of a practice coaching capability within each of those organizations, who then went out and worked with each of those 31 practices over the course of a 2-year period. That work was really centered on building and developing and applying a quality improvement framework that really helped the practices think about and address health equity and close disparities of care for the communities that they were serving. In addition to that coaching capacity and support, both our provider organizations and practices were provided seed funding to engage in the initiative. For our provider organizations, that was to support their coaching capacity, and for the practices, their investment and work related to these quality improvement interventions. And finally, that all came together with our partners in hosting a variety of different technical assistance learning events, virtually as we are gathered today, but also in-person convenings that we hosted every 6 months down in Los Angeles with all the partners and participants together in a room to talk about this work and to advance and achieve our goals. You can hear more from both Dr. Azorin and Tweedy Medical Group, and also another one of our practice participants, ReadyCare Medical, in these practice videos that are on the slide here. And I will share links to these videos if they are not already being dropped in the chat. They're about 5 minutes each, so 10 minutes in total, but really worth learning a little bit more about what each of these practices did over the course of 2 years to really drive change within their practices. So what did we achieve? So after the 2 years, I'm delighted to say we hit those goals that we had established way back in 2023. We saw meaningful and statistically significant improvement in those three clinical areas that we had identified. So again, related to diabetes, hypertension, and colorectal cancer screening. And in achieving those results, we also built and developed the capacity of the practices and their care teams to facilitate and engage in this type of quality improvement work, which you can see reflected on the slide here. The spider diagram that is on the right-hand side reflects the results from a practice level assessment that we conducted over 3 different touch points within the collaborative, with each of those cascading circles representing where they started in Equip and where their journey ended. So what actually made the difference for these practices and sort of impacted the results that we shared just there? I want to go back to Dr. Azorin's words at the very beginning. This work was really facilitated by building trusting relationships between the practice and the community that they were serving, between our practice coaches and those and the practices, and between ourselves as the technical assistance lead and our program partners. Without those trusting relationships, I don't think any of this work would have been possible, and we wouldn't have achieved these amazing results that we're able to share with you today. The work was really sort of foundationally built upon providing a quality improvement framework, a common quality improvement framework that really focused on equity, that was shared with our coaches and our practices through a training that our organization offers called the Improvement Coaching Workshop. We hosted this on multiple iterations of this event over the course of the program, and it really provided a framework for all the interventions that sort of laid on top of this over the course of the program. And in doing so, our practices then really lent into using data. And I think Jill set this up really well, talking about complexity. These small practices have multiple relationships with multiple IPAs, with multiple payers. And not just in the Medi-Cal space, which was where we were focused, but across multiple product lines. And so a lot of the work was helping those practices understand the data they were receiving from their payer partners, from their IPA partners, and really how to leverage that information to support improvement and to facilitate change. And then working with those practices and the care teams that they had on site to really think about workflows that they could put in place to leverage that data, to engage their community, to facilitate meaningful change. And health equity and a focus on health equity was a thread that was sort of a core component of the work over that 2-year period. You can see on the slide here some reflections that our participants shared. I won't read those out, but they are there for you to take a look at. So lessons for the future and what made this possible and what made this significant. I would say this is a very quick overview of the Equip LA program. I would be happy to talk about this in more length if you have questions, and welcome those in the chat. I may have a few moments to address some of those. What we wanted to summarize from Equip, the trainer model that we adopted here, so leveraging those IPA and health plan partners and to provide those coaching resources to the practices. I think, as Jill mentioned, not only the issues around complexity, but these practices wanting a playbook and actually being willing and wanting to engage in this type of work was really apparent. And so providing that resource really made a difference. Data is crucial, and again, cutting through that complexity. So working with the practices to get a fuller sense of how they were managing their panel of patients and what interventions would really be meaningful in the communities that we're serving. I mentioned we had a quality improvement framework, an equity-centered quality improvement framework that we really was the cornerstone of this work. But those interventions were tailored to each of our 31 practices, their care team, their community members, and tailoring those solutions to what made sense in that setting. I've mentioned this, I think, already, but this was really all built upon spending time and energy to build trusting working relationships between all the partners in the program. And through those trusted relationships, I think all this work was possible. Our small practices have a lot of challenges and they are dealing with a lot of complexity. So setting realistic expectations on what is achievable and on what timeline. I think going back to that tailored both support and goal setting, making sure those are reasonable for our practices. I think a reflection from the EquipLA program is centering equity early and often. The goals that I shared a few minutes ago, we actually reflected upon those in the program and called that our North Star. And every time we came together, whether in an in-person setting, in a virtual setting, our North Star was present and it was discussed, it was mentioned, and it really provided a wonderful framing for the conversation. Even if those conversations were challenges, it always brought us back to why we had gathered and the intent and purpose behind this work. And with that, I am going to hand it back to Fifi, I think, to set up some breakout conversations.
Yeah, thanks so much, Peter. I'm actually noticing we're doing really good on time. So you can take down the slide. I think before we transition to breakout groups, I wanted to just open up the floor to see if there are any questions. So thank you so much to all of our speakers. We really appreciate all the insight you've shared with us today. We have a lot of participants on the line. So if there are any questions or reflections that you have, um, we have a few minutes before we transition to our breakout groups.
Fifi, I noticed there's a question in the chat that I can go
Yeah,
ahead and read and we can address from Gabby. Does
yes.
EquipLA or other orgs also support these practices with greater participation and value-based models from CME to maximize reimbursement? Peter, do you want to take that and I can add anything?
I can speak to that. I'm not sure I would relate this to Equip, but certainly work that CQC is leading. We are running the California Advanced Primary Care Initiative, and we have a payment models demonstration project underway. I'm actually working with small independent practices up and down the state. We have about 100 or so primary care practices engaged in a common payment model supported by three commercial health plans, CVS Aetna, HealthNet, and Blue Shield of California. And not only are they participating in this pilot payment model, it's essentially a capitated model. They provide a per member per month sort of population health payment on top of incentive dollars, but they're provided with technical assistance and a common data platform. So going back to some of the lessons from Equip, data being critical to this work and actually to facilitate engagement and value-based payment. There is a common data platform to share performance information with the practices in those programs and actually to focus their improvement efforts to earn and maximize their dollars through that program. And Diana, I'll hand it back to you.
Yeah, and I'll add that though this program, EquipLA, did not specifically focus on VBP models. It was all the baseline competencies you would need to be successful in VBP. And in the evaluation, we did ask participants, and 90% of them said that EquipLA increased their ability to access performance incentives from their IPs and their health plans. So they were moving in that direction.
Great. Thank you, Gabby,
Can
for
I,
that question. Yeah, go ahead,
sorry,
Peter.
Phoebe. I was just going to, one more thought that jumped into my head. And I think one of the other pieces that has come out of the EquipLA conversation, and my thanks to Diana and CHCF for sort of supporting this body of work as well, is CQC has continued to engage the health plans in LA County, particularly the Medi-Cal plans. And we're actually coming together and trying to create a common data solution for the county to try and address some of this complexity that we identified. And also I think Jill came out of Jill's findings as well.
Thanks, Peter. Joe, I think you came off on camera briefly. Did you have a question? All right. Any other questions or comments? You can also drop them in the chat. I see something from Beth. For data exchange, was the focus on using plan rosters or also seamlessly submitting data through claims encounters and through HIE? It feels like small practices struggle with submission specifically.
If this is related to Equip, We were leveraging data from both our health plan partners and the IPAs, and sharing that with the practice participants. We did not necessarily leverage engagement with an HIE in the Equip project.
Beth, did that answer the question you had?
It did. Thank you.
Great, wonderful. All right, I'm not seeing any other hands raised or comments in the chat. Okay, so next we'll move from, this learning and listening to more of a planning action. So we'll jump into our breakout group discussions. So in the chat, I'm going to send this now. You'll see recommendations that Jill already shared, and a short discussion prompt. So Bree will open up the breakout groups, and then please choose a breakout group that's based on either your organization type, the work that you do, or your interests. So we have 3 of them that are aligned with the recommendations. And in your groups, focus on the 2 questions. So how can you coordinate action with others in the next 3 to 6 months? So others in your group. And what is one concrete step you can get to get started? So I'll just say you don't need a full plan, but just identifying one clear next step to get started. So our speakers will be floating and joining different groups to listen in and share thoughts with you as well. And if you have other questions that come up, please feel free to ask. And yeah, now we'll move into our breakout groups, and then we'll bring you back into the main room before we wrap up the session. Welcome. I think that's everyone. All right, so I know there were a lot of good discussions happening. Sorry to have to cut that short. When I popped in, one group was sharing about how we tailor investments to meet the different needs of practices, and then another was sharing about how we leverage AI. So that was pretty interesting. I just wanted to bring everyone together and see if we could all share insights with each other. So there are 2 groups, the other group and then the pair group. So if you want to just unmute and share, some new idea that you got in the group or any questions that you may have for our speakers.
I'll speak up over here. We were talking about concierge medicine as well as AI in our group. And there was a comment made that there is a perception that concierge medicine is only for, wealthy patients. But I didn't get a chance to mention this. I wanted to mention there are groups that are throughout the state of California that can help guide if you decide to go with direct care or concierge medicine, as it's called. It doesn't have to be expensive. One of the most successful physicians that I've seen in that direct space is a very small independent physician in Grass Valley, which is an extremely rural area. And she has managed to base her practice in that direct care space and concierge medicine while keeping her rates affordable for her patients and providing the highest level of care. So I just wanted to drop that in kind of for the group as a whole. It's something to consider as we're looking at these times in healthcare where it is so difficult for physicians to stay independent and manage their practices efficiently without putting in, 18-hour business days. It's just something to keep in mind that we are seeing a shift towards direct care and concierge medicine in all aspects, regardless of patient abilities to pay. There are programs available for others.
Thank you, Andrew. Any other reflections or other comments, maybe from conversations that were happening in the breakout groups that you didn't get to finish?
Fifi, I think I'll just add, I think we had a really robust discussion about AI and its
Yeah.
potential. And I think we're all eager to see its potential, particularly reduce things like administrative burden, address some of the complexity issues that were talked about during the presentation, and also some reservations about how quickly it's rolled out, um, how it's using patient health information, and to actually ensure that it's not exacerbating inequities or disparities that we know exist today. And many of these systems are built on a knowledge bank reflective of the healthcare system and the nation where we all live. So I think positivity mixed with a little bit of hesitation, but recognizing we're kind of heading in this direction. So it's for all of us to be cognizant of where we go.
Yes, absolutely. I couldn't agree more. It's here to stay. We just have to embrace it and think about how to leverage it to benefit or to amplify the work that we've been doing. Thanks, Peter. What else came up in the groups? Anything else? Yeah, Jill, I see you're unmuted.
Yeah, I'll just mention that within the pair group, which was just a terrific conversation about what in particular the IHP and Planet San Mateo are doing to support independent practice, which was really just fantastic to hear about. IHP has built an entire unit with 9 FTEs that has a QI orientation, which I love, and still, because there are so many small practices, really need to be strategic about where they focus their energies. Or so many more small providers than there are staffers and the time to support them. So really focusing on the quartile performance that the providers are in and tailoring the available staff to support those lower performing providers in the network to improve their performance and their member performance. And on the HPSM side, they are doing a really creative sort of pilot to essentially directly invest in practice transformation support for their provider network. And are really, I think, paying a lot of thoughtful attention to what happens with that and what results they get. And what I love about both is this sort of learning opportunity. And the IHP folks started, with 3 and have grown to 9. And I know Health Planet San Mateo built a lot of really thoughtful evidence and data, including really wanting to create a rationale for whether to make this investment based on their pretty deep understanding of what happens in their networks when practices are bought out and seeing negative sort of outcomes associated with small practices being purchased, both on the patient side and on the provider side. So really enjoyed hearing about the innovations that are happening at IHP and HPSM, and thank you for that. And we had IHA there for CAPC as well. So great to have that participation too.
Yeah, thank you so much, Jill, for recapping that. All right, so we are getting close to the end of time. So I hope everyone was able to have some insightful discussions that can help support the work that you're doing. Peter also put his email in the chat for conversations that can continue offline. So before you jump off, I want to ask you all to stay on to just complete this 3-question poll. As I mentioned earlier, it just kind of helps us design content that is relevant and responsive. But yeah, with that, thank you all so much. Thank you so much to our speakers, Peter and Jill and Diana, for being with us today, and then all of our participants. We hope to see you at future CIN events. Have a great rest of the day, everyone.
Thank you.